morning. My name is Asha Talati. I'm a fourth-year resident at University Hospitals. I apologize that I'm not able to present in person, but thank you for giving me the opportunity to present remotely. Today I'll be talking about my research, improved adherence to C. difficile isolation protocols through interdisciplinary education. Next slide. I have only one disclosure. This project was funded by the Department of Graduate Medical Education by a grant called the Innovations Grant in 2015. Next slide. Nosocomial infections, such as Clostridium difficile, have increasingly become a cause of hospital-acquired morbidity and mortality. Between 2000 and 2015, C. diff-related deaths have increased tenfold, from over 700 to greater than 7,000. Furthermore, it's estimated that hospital-acquired infections contribute to greater than $1 billion annually in healthcare-related spending. Patients at highest risk for these infections include patients on prolonged antibiotic therapy, those undergoing prolonged hospitalization, immunocompromised patients, or those having undergone recent abdominal surgery. Finding ways to reduce such nosocomial infections have become a goal of major hospital systems nationally, and these goals have been promoted by the Institutes of Health as well as the Joint Commission. At our institution, overall reduction in nosocomial infections, including the spread of C. diff, has become a hospital-wide quality initiative, and this project has fallen into that. In terms of our objectives, we hope to describe the implementation of an interdisciplinary, team-based education module and the subsequent change in adherence to C. diff isolation protocols amongst our care providers of gynecologic oncology patients at our institution. We hypothesize that the utilization of a team-based education system will, 1, improve the knowledge of nosocomial infection spread, and 2, improve adherence to appropriate isolation precautions. In terms of our study design, we have 3 primary components. Our first is a pre-intervention component in which we attempted to establish existing C. diff infection rates amongst GYN patients that presented with symptoms suggestive of C. diff infection. We also reviewed the percentage of times that we as providers were compliant with isolation precautions amongst the patients that we tested. Our next component was an intervention in which we educated all of our staff, including nurses, patient care technicians, residents and other health staff, as well as attendings regarding appropriate isolation precautions in the setting of C. diff, as well as treatment and prevention. After the intervention, we again assessed our primary outcomes, which was again looking at how often we were compliant with C. diff isolation precautions, as well as what our rates were amongst the patients that were tested. Again, looking at our study design, the first component is our pre-intervention component. Our primary inclusion criteria for this portion of the study included those admitted to the GYN oncology service, and that was only to patients that were hospitalized on Seidman Cancer Center 6th floor between 2012 and 2014, and patients that had the C. difficile PCR sent. There were 3 primary outcomes that we looked at. We looked at the utilization of a contact plus precautions order placed within 24 hours of a C. diff PCR order being placed by a physician. We also noted whether the order was acknowledged by a nurse within 4 hours of placement. We determined that 4 hours was an adequate amount of time for acceptance of this order after surveying nurses on Seidman Cancer Center. And finally, we looked at what the infection rate was amongst women that were actually tested for C. diff infection. In terms of our second portion of our intervention, we promoted a educational module that was completed by, again, all staff that were working with GYN oncology patients on the 6th floor of Seidman Cancer Center. In terms of our patient population, and for the intervention component, in terms of our staff population for the intervention component, the primary things that we focused on for education included risk factors for C. diff infection, appropriate testing and the tests that should be utilized for diagnosis of C. diff, the use of contact plus precautions, and again, the treatment of the infection itself. As you can see here, some portions of the education module also discussed how to appropriately document whether patients were being isolated in the electronic medical record. Our final component of our study was post-intervention, where we tried to track whether we were now more adherent to isolation precautions and appropriate treatment of C. diff. In our post-intervention component, we tracked patients between 2014 and 2015 who again were screened to be suggestive of having C. diff and tested for C. diff. We again looked at our primary outcomes, which was whether a contact plus precautions order was placed and whether the order was acknowledged in an appropriate time frame. Finally, we looked at all of our results between the pre-intervention component and the post-intervention component and analyzed it using descriptive statistics. Primary outcomes were compared using Fisher's exact test. In terms of our results, 61 providers were surveyed and educated, and the voluntary completion rate amongst all staff invited was 73%. As you can see on the left, these are the differences in our pre and post-test results. Of our 61 providers that were surveyed, we saw an improvement in terms of results of our patient care technicians as well as our nurses, equaling about 3 additional questions right and 2 additional questions right amongst those that were surveyed. A comparison of our primary outcomes is seen here next. What we'll note is that our pre-intervention component, again, was looking at the years 2012 to 2014, while our post-intervention data was being tracked between 2014 and 2015. In our pre-intervention component, 138 patients were tested for C. diff infection, while in the following year, only 38 patients were tested for C. diff infection. We saw a decrease in the number of tests, in the number of patients that tested positive for infection between 1.4% to 0% amongst those who were actually tested for C. diff itself. The largest change that we saw is the percent of patients that had appropriate isolation orders placed, ranging from 0% initially prior to our intervention, increasing to 78% after the completion of the intervention. There was also an increase in the number of tests that were acknowledged within the appropriate time frame. These were statistically significant. In terms of our intervention, we can say that this was an effective intervention to improve our adherence with placement of isolation precautions orders and acceptance of those orders in an appropriate time frame to help prevent C. diff infections. Some strengths of this study include the fact that it looked at one primary group of providers over a continuous time frame from 2012 to 2015. One of the reasons that we limited the study to just the 6th floor of Seidman Cancer Center. Furthermore, we were looking at a homogeneous patient population, looking only at GYN oncology patients, and we had a great survey completion rate amongst the patients, or amongst the providers that we surveyed. Some limitations of our study include that it was limited to just one patient population, only GYN oncology, and to one staff cohort, which was providers of GYN oncology patients. It's hard to say whether this will be applicable to a hospital-wide system. In terms of our conclusions, we suggest that there was increased knowledge about C. diff based on our test results, and there was an increased compliance with precautions, again, based on our pre- and post-intervention primary outcomes. In terms of future directions for this study, there have been sort of 2 directions that we have already began pursuing. We would like to turn this into a system-wide education throughout university hospital systems in order to help decrease our nosocomial infection rate. And finally, through utilization of this study, we were able to notice that one way of avoiding provider error is through creating an order set that will prevent us from having a 2-step process to ordering isolation orders when we are testing patients for C. diff. Through this, it has strongly helped reduce the number of times that we forget to place patients on appropriate precautions orders. We do still have to collect data to see whether the order set helped prevent infection spread itself. These are my references. I apologize, I won't be able to take questions at this moment in time, but I'm happy to take questions at a later date and time. And I would like to thank my mentors for this project, Dr. John Nakayama, Dr. Kim Gatesy, our OBGYN research faculty, as well as all participating nurses and staff members on Seidman Cancer Center, including my co-residents. And finally, I'd like to thank my husband for helping me record this today. Thank you so much.